part 2 of Pearls from the OR, World Spinal Column Society's virtual deformity talk, our virtual deformity meeting. Yesterday was a really good day. Those of you who were there will have seen. We're hoping to have as good a day. We've got some great speakers and some interesting talks lined up. And now I will turn things over to our moderators. From Portugal, we have Paulo Pereira. From Izmir, Turkey, we have Mehmet Zeleli. And from Belfast, Northern Ireland, we have Nikolai Pev, who is also going to be our first speaker. Take it away, gentlemen.
Thank you. I think it becomes a very interesting meeting, virtual symposia on degenerative spine, deformity of spine. Now I want to introduce Dr. Nikolai Pev, who is a consultant neurosurgeon and spine surgeon in Belfast, based in the Royal Victoria Hospital. And he will tell us about the role of limited surgery in degenerative scoliosis. Nikolai.
Thank you so much, Mehmet, and thank you everybody for joining for Pearls from the OR2 today. I'll try to share my my screen with you in a second. Do you see it already or not yet?
Not yet.
Not yet.
Okay, probably it's coming. Okay,
yes.
Right, so greetings from Belfast. As it was announced, I would like to talk to you today about the role of the limited surgery in degenerative scoliosis. I would like to start with this slide, which I like, and I have seen, you may have seen it before. That's a good demonstration on the development of the different surgical techniques. As you can see here, we have the first interbody option somewhere in the middle of last century. And then we have the first minimal invasive option somewhere at the end of the century, and really significant progression and implementation of these minimal invasive options over the last 20 years. So today we have many different options for different conditions, and we can choose from different surgical techniques, open and minimal invasive. I got this company data back in 2019, and it appears that about 3% of the surgeries, spinal surgeries, are done minimal invasive worldwide, while 30% of the surgeries are MIS in the United States. Hopefully, the coronavirus did not change that, but from what I hear, surgeons are even more motivated to do MIS because this shortens the stay of the patients in the hospital and will decrease the chances of communication and transmission of the virus. So some considerations, speaking about the degenerative adult scoliosis, exponential growth in the field of degenerative spinal surgery, as I have already demonstrated with the previous slide. A variety of surgical interventions are currently available to manage different components of the degenerative conditions. We see transition of the extensive open procedures slowly being combined or even replaced with minimal invasive options. If I have to define the adult scoliosis, it will be a spinal deformity with a scoliotic angle of over 10 degrees in a skeletally mature patient. According to different publications, the prevalence will be between 8 and 68% of the population. And while the main presentation is deformity, the main symptoms of your patient will be back and leg pain, sagittal and coronal imbalance, and advanced stage at presentation, and also comorbidities. This is a good table that gives good overview and comparison between the two main forms of scoliosis in the adults, adult idiopathic and adult degenerative. You can see that with the adult degenerative, you have patients with, you have older patients. Spinal stenosis is more common. The scoliotic angle is smaller comparing to the idiopathic. You have rare compensatory curve, and then the rotation you can see only at the apex of the curve, and you see coronal and sagittal imbalance with significant lateral subluxation of the vertebral body in many of the cases. Different classifications, like any topic, you can find different classifications which will define different types of patients. EBI classifications defining 3 types, Scoliosis Research Society 6 type, Schwab classification, and the last one, which I think is probably most comprehensive. It's a combination of SRS and Schwab, and it's the first classification that is taken into consideration the sagittal balance and the other parameters which are important for the global alignment. Okay. So if I have to say a few words on progression, pathophysiology and natural history of the adult scoliosis, we see a progression of degenerative changes. We see asymmetrical degeneration of the disc and the facet joints, asymmetric load of the spine. Quite often these patients will be osteoporotic, women after menopause. And usually it will start after age of 50 and then above that. And the prevalence of the curves will increase with the age. You will see with aging, you will see curves over 30 degrees. You will see asymmetric degenerative changes, lateral subluxations. And there is research that suggests that if L5 vertebra is above the intercostal line, this scoliosis may progress, and there is a tendency for further progression. Clinical presentation, it will be mainly back and leg pain. About 60–80% of your patients will complain of back pain, which will be mainly on the convex side. And the mechanism of the back pain will be degenerative disc and facet joint changes or muscle fatigue due to the imbalance. Radicular symptoms usually will be on the concave side, and it will be associated with foraminal stenosis in up to 80–90% of the cases. The mechanism of radicular problems will be nerve overstretching, foraminal stenosis, pedicular kinking, and you will have also deformity, which will give you sagittal and coronal imbalance with significant back pain issues and quality of life issues. So surgical treatment, if you consider to operate some of these patients, you have to take on board the following considerations. First, of course, and very important, is the general condition of your patient with the comorbidities. Presence of the comorbidities will be a significant risk factor for complications, especially if you are planning extensive surgery. Osteoporosis is an important one, because if you don't consider that, and if you have osteoporosis, that can give you a lot of headaches after that with screw pullouts, loss of correction, pseudoarthrosis, cage subsidence. Coronal and sagittal imbalance is also important, and planning for your surgery, you have to consider that, and you have to see if you can correct that or not, because if not corrected, this also can give you bad postoperative results. So surgical options vary from decompression only to extensive surgical corrections. If you think about this, about treating your patient only with decompression, you have to consider this only for small scoliotic curves without subluxation, or if you have a very old patient with a lot of comorbidities and you cannot offer anything else. It will be not indicated at the apex of the curve with severe lateral subluxation and rotation. And if you do laminectomy and facet joint resection, you may trigger further instability and deformity. Surgical options with decompression and limited short fusion. usually does not involve the fusion of the whole curve, but only the decompressed area. It's a good choice in moderate scoliosis, scoliotic curve, and mild subluxation. Adjacent segment disease will be risky if you consider that. Degenerative changes may be accelerated outside of the fusion, and fusion should not be stopped at the apex of the curve. And finally, decompression and long fusion with deformity correction. This comes to consideration with severe lumbar scoliosis, with severe subluxation of the apical vertebra. Restoration of the lumbar lordosis and sagittal imbalance is usually good, but sometimes it's difficult to achieve only with posterior surgery, and you have to consider anterior column support, osteotomies, and more extensive options. So some of the important considerations when you decide what type of surgery you have to do. Fusion should not be stopped at the apex of the curve, otherwise you will have problems. The junctional kyphosis should be included in the fusion. If you have severe lateral subluxation, this should be included in the fusion. Spondylolisthesis and retrolisthesis is also advisable to be included. The upper instrumented vertebra should be the first horizontal vertebra. There is some debatable parameters which some of the authors recognize, some are not. For example, many authors advise that you have to finish up to T10 because this is the first stable vertebra, but is still controversy with that. The distal vertebra, according to some of the publications, should be at L5. But some of the authors suggest that you have to go down to S1. Of course, if there is degenerative changes, then this is no debate. But if the L5 S1 is healthy, then this is debatable. Fusion at the sacrum will give you better correction, but also there is chance for more significant complications. Applications of the new technologies and techniques and the principles of minimal invasive surgery has the potential to broaden the indications of the relatively simple solutions. So if you, for example, consider decompressive surgeries only, tubular retractor, interlaminar decompression, endoscopic surgery, foraminoplasty, interlaminar decompression are good options, and you may, like that, broaden the indications of this limited option, which is the decompression only. And with applications of the new technology, you will have a less likelihood for post-operative development and triggering the changes and further complications. So decompression and short fusion, minimal invasive fixations, expandable cage technology, endoscopic interbody fusion options is also something that you have to consider, and that will give you a chance to do to achieve more with less extensive surgeries. I'll give you a few examples. You can see this patient is that's a patient which is in the 8th decades, significant degeneration, multi-level degeneration. However, after serial of injections, I have managed to locate L4, L5 unilaterally only as the main generator of the pain, and I have offered endoscopic fenestration, endoscopic foraminoplasty. I don't know where my video has disappeared, but probably I can. Okay, this was endoscopic fenestration of the right side, and the patient did relatively well after the surgery. Significant improvement of the radicular pain. Of course, there were post-operative back pain issues. However, if you explain to the patient that you cannot make them like new and you cannot send them back to them 20s, most of them understand and they accept if there is significant improvement of the main symptom that they are struggling with. If you, this was another case, which this is a woman in her 70s, which had grade 1 spondylolisthesis and also deformity, back pain issues, but mainly leg pain issues. She was complaining with bilateral L5 leg pain because of the grade 1 listhesis, significant osteoporosis. I've decided to go with augmented screws. Nowadays, you have not only augmented screws with bone cement, but you have different other options which will be good and you can consider for your fusions with these osteoporotic patients, and this will give you reassurance and stronger pull-out. For example, you can go for hydroxyapatite coated screws. You can go for outer diameter, increased outer diameter screws, cortical threads, and all this is giving more hold, and you can go with shorter options. Lately, I have started using expandable cage technology as well, which gives me better restoration of the angles. You can see this case was a patient who had grade 2 spondy at L4 at L5S1 and adjacent L4 L5 degeneration. The main radicular symptoms were coming from, interestingly, from L4 L5. I have established that with nerve root injections bilaterally, and I have decided to do transdiscal at L5S1 to try to address the back pain issues, and then cage, expandable cage at L4 L5. Good postoperative results. You can consider lateral interbody options as well for recovery, for restoring your curves and for addressing issues. And this is another minimal invasive option which can give you good results. And finally, I would like to conclude with this slides. I like this to conclude with that because I would like to emphasize that the concept of the surgery. Performing surgeries, usually we need to locate a target deep in the body. We have to create path, we have to perform the surgery, and then we have to restore that path. We have to close the wound. Doing that, we inevitably damage normal tissues, and so we leave footprints and fingerprints. And the modern drive of the surgery is to leave less and less. And by applying new technologies and new techniques, we do that, and we constantly improve. And this is the way to do more with less extensive surgeries. Thank you.
Okay. Thank you, Nikolai. I give the words to Paulo to introduce next speaker. We will discuss later.
Thank you, Mehmet. And our next speaker is Professor Abdel Fattah Saoud from Cairo. He's a professor of orthopedic and spine surgery at the Ain Shams University and is the vice dean of the university. And Professor Saoud is also the past president of the World Spinal Column Society. So it's Professor Saoud will talk on the other side of this spectrum about open surgery for degenerative scoliosis. Please go ahead.
Thank you, Paolo, for the nice introduction. Can you now see my screen?
Yes, perfect.
Okay. Good afternoon for me and good morning for some people on the other side of the globe. I'm happy to talk about open surgery for degenerative scoliosis. Nikolai gave some insight about the pathology, but I'll have to repeat some of the pathological facts during my talk, but I will not do this extensively. Thanks for him for the nice presentation that made my life easier. But maybe I was assigned to give this talk because I'm an old-fashioned guy who still thinks that open surgery for degenerative scoliosis would do a better job. This is, by the way, the Sifran Palace, the seat of higher administration of my university, Ain Shams University, which is the biggest and the third oldest in Egypt. And now I'm talking to you exactly from this office, which is overlooking the fountain. Doug Orr has given me a great visit to my office here. I was asked to start my presentation by a case, but I will partially do that. This is what most of the radiology of patients of degenerative scoliosis will show you. That's the plain X-ray when there is usually a double curve. Usually both are structural. At least in my country, when everyone comes to treatment very late. The most important is that there is a concavity and there is a convexity, and there are a lot of pathological issues to talk about here. So why this is a partial case? Because I'm going to give you the rest of the scenario after talking a little bit about pathology, because we need to have answers for those questions. Where is the pathology? Symptoms and clinical scenario is very important here. What are the solutions, and then how to execute these solutions. So there are three stages of degeneration of a motion segment. Stage of dysfunction, where the motion segment is a little bit dysfunctional because of degeneration of the disc, multiple tears of the annulus, and stretching of the ligaments, but still it is not perfectly functional, but it's not yet hypermobile. And then the other stage, or the next stage, is instability, when the facet joint changes become more persistent and there is laxity of the capsule and hypermobility. What the motion segment tries to do is forming osteophytes, thinking that these osteophytes around the facet joints mostly and encroaching on the foramen are going to stabilize the spine. This is very important, and this is the stage of instability. And when these changes are stable enough and more osteophytes are formed, and the ligamentum flavum is thickened and infolding inside the canal with a lot of problems, the motion segment is settling with these changes. So it's now not hypermobile, it's stable, but stable with a lot of stenosis. This stenosis can be central stenosis or lateral stenosis, and this lateral stenosis could be lateral recessed stenosis or far lateral syndrome. I need to remind you also of some of the important pathological points in degenerative scoliosis. Do have to know that osteophytes and degenerated facets are not symmetrical, happening more on one side than the other, and that's why scoliosis form. And since deformity begets deformity, so the more scoliosis you get, the more chance of advancement of the scoliosis. You need to know also that lateral bending in the spine, especially in the lumbar spine, does not happen without rotation. So rotation is an important element, and then translation of those segments begin to happen, and with this lateral translation or olisthesis, the pathology becomes more persistent, and osteophytes do tend to form more at the concavity of any curvature. Take this in consideration, and take also in consideration the fact that at any particularly given level, if there is compression, there are two nerve roots that you have to take care of, the exiting and the traversing nerve root. And also you have to think of the goals of your surgery before touching the patient. Normalize and balance the sagittal and coronal spinal contours, prevent further progression, fuse the least number of segments, but the least number of functional segments, protect and decompress spinal cord and nerve roots, and obtain solid biological fusion, improve mechanical pain, and avoid perioperative complications. I still like this Linke and Silva 6 levels of operative treatment, and I'm going to talk about this during my case presentation. So let's now complete the first scenario that I showed you some of the radiology of it. This is a case scenario number 1, 78 years old female, long history of back pain, history of L345 radiculopathy. So now the patient is coming for your care, just forgetting about back pain. The back pain was years ago, and now it's radiculopathy. There are gait changes, more falls, right-sided partial foot drop, and drop of the toes as well. But this patient is cardiac, previous coronary stenting and on Plavix, moderately impaired renal function, serum creat 2.4, creat clearance 25 milliliter per minute, fatty liver. Anesthesia consultation showed that this patient could be operated upon, but not a long procedure and avoid any intraoperative hypotension. So again, having these investigations done or radiology done and thinking about the same thing, where is the pathology, symptoms and clinical scenario, solutions and execution. So step one questions should be answered, specify the route affected. EMG may help, specific injections can help. Compression only or instability. Dynamics, CT, dynamic MRI can help you to see if there is compression only of the roots or instability of specific segments. See the sagittal balance, full standing x-rays, and you've heard a beautiful talk from Jean-Charles Lewak about this yesterday. Gait analysis is very important, and if there is compression, would your plan after doing all this investigation for fully decompressing the compressed nerve roots would destabilize significantly some segments? This is a very important question to deal with. With this scenario, we can go to the level 1 treatment that Nikolai Piv talked about, which is only radicular decompression. But this is having very important preconditions. The patient should be having radicular compression proven, no instability, balanced or compensated spine. Most probably decompression will not cause significant instability because the patient is in the stage of stabilization and there are anterior osteophytes that are forming in the segments that you're going to decompress. No more than 2 millimeters of subluxation or olisthesis that I talked to you about. And the complaint should not be back pain, significant back pain. And the curve should be less than 30. And there should be no significant hyperkyphosis of the dorsal segments. Then decompression only would be good. In this short video, I'm showing you that what you're looking for is that to decompress all the area around the facets. So it's the foramine. So this is where you have to go and plan for your decompression and see if enough decompression is going to be without destabilizing or with destabilizing effect on these segments. The other thing that you have to see and think about is what's shown in this cartoon is that you're dealing with two nerves at each segment, the exiting and traversing nerve roots. So the area of concavity is where you look for decompression, and for each segment and around your facets, you need to decompress both the exiting and the traversing nerve roots. There are two nerve roots in concern here, and you have to think about them both. The second scenario is pure radiculopathy, but unstable segment or segments that you're going to decompress, or that when you're trying to plan for decompression, you will find that you will necessarily need destabilization of those segments. Back pain should be a minimal issue again, and curves should not exceed 30 degrees by Cobb method, but the subluxation here is a significant issue when the subluxation, the lateral subluxation of those segments is more than 2 millimeters. So it's not enough here to cause decompression only. You need some fixation, but this fixation with those preconditions could be directed only to decompression and stabilization of a specific segment. So like this case, the lateral olisthesis is more than 2 millimeters. There is no significant hyperkyphosis. So you can go for decompression and fixation of these segments. And you can even correct the deformity using two standard methods that I'm going to show in these short videos. It is distraction of the concave side, like I'm showing here, and it is compression of the convex side, as shown in this short video. So by this and doing limited fixation to the area that is destabilized, this is the next level of treatment. And the third scenario, when the entire lumbar curve, in addition, is added, when the entire lumbar curve needs decompression and fixation, and this is happening usually when the primary symptom is primary back pain. So when the back pain is a real issue for the patient, you need to decompress and fix the whole lumbar curve with proper decompression of all the nerve roots involved, and do fixation of the whole curve. And this is happening with curves that exceed 45 usually, and 2 millimeters more of subluxation, and there are no enough anterior osteophytes, so the patient is still having mobile spine that needs real fixation. And this is level 3 of treatment. I will show you two other levels of treatment before I show you practically how to correct these deformities. Level 4 of treatment, when you need to add interbody fusion methods to get more correction of lordosis, especially in flat back syndrome, and in patients who are having high risk of pseudoarthrosis, like smokers and patients with diabetes and osteoporotic patients, when you need more methods to avoid this pseudoarthrosis. And level 5 of treatment, when there is a global and coronal imbalance, and you have a problem with the hyperkyphosis of the thoracic spine, when you need to fix and correct the whole deformity, both lumbar and thoracic, in order to get enough correction and balanced spine and good gait. I will show you now how to do this correction with the short videos on a demo. The first trick is to have to contour your rod in the proper direction, having enough lumbar lordosis and enough thoracic kyphosis. So now this rod is in the perfect position. Then you apply it to the deformed spine in situ, like what the deformity permits, as shown here in this video, and then do some maneuvers in order to reduce the spine first to the rod, and I will show you how to do that, and then rotate this rod to the normal direction, so it takes the whole spine to the normal direction with it. So now I'm applying this rod to the deformed spine, as you see here. So the rod is in the correct position, but the spine is not. So we will apply the rod in the deformed position. And then you will face two problems. The first problem is that this is the rod that we know in the perfect position anatomically, but now is facing the wrong direction. Those screws are going to be far away from the rod. So part of the reduction of this problem, and as an important step, is to get this spine up to the rod. There are two ways of doing that. The first way is to put what we call persuaders that are attached to the heads of the screws, like this persuader. And by putting the cap and then pulling the head of the screw up to the rod, you are correcting the deformity in two ways. You are getting the vertebra to the rod, so significantly reducing the deformed spine, and you will do by default some derotation as well. The problem here is that with osteoporosis of most of our geriatric patients, this use of persuader is not ideal for some of our patients with low bone mineral density. So alternatively, we can use what we call reduction screw that I'm going to show you now, which helps reducing those vertebra towards the rod without causing significant pull out. So now these persuaders are applied to the heads of the screws, putting the caps. There's now significant reduction of these vertebrae towards the rod, which causes both reduction of these vertebrae and some derotation as well. What you can do to avoid the problem of pull out is to use reduction screws that I'm going to show you now. This is the kind of reduction you get after using these persuaders. And these are exactly what we do for open surgery for our true cases. So now the whole vertebra is reduced towards the rod. The problem of the pull out can be solved with using reduction screws that are going to show now on the screen in few seconds. You can see now how significant this reduction is. Alternatively, you can use this. You can use the reduction screw that's going to show now on the screen. The good thing about the reduction screw that you're going to see now is that there are multiple threads, a full length of threads. So the cap takes from the beginning of the screw from here, and all the way through, when you tighten the cap, it causes the reduction without much of pull out on the screw. Now we are going to reduce the spine towards the exact position. Now the rod is in place, and you get these holders to tightly hold the rod, which is now a rod, which we know having a good curve and applied to the deformed spine. So when we rotate this towards the right direction, we get very good reduction, as you are going to see now. We will make now the lumbar lordosis looks towards the real lumbar lordosis we need to have, and the thoracic kyphosis to look to the anatomical place we want it to be in. And then we tighten the caps, and you will find that there is significant reduction of the spine towards the correct contour. Now you can see the effect of putting the rod this way and doing the same with another rod to the other side will cause another significant reduction of that curve. You can see this now, doing the same, putting it in the deformed position, and then get it rotated towards the correct direction will cause more and more reduction. Also, you can add, as I said, in one level of treatment, some interbody fusion method to enhance the fusion possibility and also to increase your lordosis. And in this short video, I'm going to show you where are the areas targeted when you are using TLIF that I use in most of my surgeries. These are the facets that you need to remove. It puts you in front of the disc space directly. When you remove this disc material and get your cage going from this area, you can put it as anterior as needed to get enough correction of that level, better lordosis and better chance for fusion. These also are photos of the areas targeted for your TLIF. Then we come to the point that was raised by Nikolai, or on where to stop downwards. This is a whole talk that takes 30 minutes in Cleveland Spine Review course. But what I can tell you shortly is that significant pelvic tilt forming part of the deformity means that you have to go and do iliac fixation. Stopping at L5, very high chance of redo due to L5 S1 degeneration, even if this L5 S1 looks good. And stopping at S1 also gives you in long constructs for correction of degenerative scoliosis, a high rate of pseudoarthrosis L5 S1. So it looks like going to, in those long fusion cases, going to the pelvis is the best solution. Then shortly, in one more minute, there is another level of treatment when the patient is having 30% correction on bending radiographs. They do not require significant osteotomy, but curves that are corrected less than 30 degrees might need osteotomies. And I'm not going to talk about these osteotomies because in the next session, you will hear about PSOs and VCR from one of the best surgeons in the world that can do that, Douglas Orr. So just put this in mind, and that will make your patient correction looks like that. Thank you for listening, and I'm ready for any questions later on.
Thank you so much, Saud. It was a great lecture and great pleasure. So we have a few minutes now for discussions. Any questions from the audience?
So may I ask you what's the well, when we talk about degenerative deformities, particularly most of the patients that I see, they tend to be like a 2 or 3 level problems particularly in the lumbar spine, and on those patients I find it quite attractive to do lateral approaches and minimally invasive fusions for those patients. What do you think about that for you and Nikolai?
So do you want to go ahead? And then I'll
No. He's talking about minimally invasive techniques.
Right.
You are the one who's blamed for that.
Okay. All right. So I'm happy with this. So yeah, definitely. I see patients which the majority of my patients, they come with not very significant scoliotic deformity. They come with minimal deformity, and usually we are talking about 1, 2, or as you said, maximum 2, 3 levels affected. And with this, I try to basically I try to avoid significant big extensive surgeries for these patients, because most of them are old, most of them are with significant comorbidities, osteoporosis, and so on and so on, and I would like to avoid big complications. Definitely minimal invasive. For me, anything can be done minimally invasive, I'll go for that. As minimal invasive as possible. Lateral options are also a significant part of my practice. And but also lately, since I started endoscopic decompressions, I tend to do that only as a first step before I consider fusion options, obviously within the limitations of the patient and if that's possible. I tend to, even if there is degenerative conditions which suggest that there is likelihood of problems after the surgery in case you don't fuse, I tend to open minimal invasive decompression first in case the patient is old, in case the patient is with significant comorbidities, and I don't mind to start with that and to explain to the patient that this could be a first step in the treatment, and things may progress further, but at least we try something which is not associated with significant complication risks.
Can I comment on that, Paulo?
Yes.
Actually, I need to note that I learned this from the Cleveland spine review courses. It's all the tools are needed to be in the armamentarium of treatment, but it's what works well in your hands. And this is very important because learning curve can affect significantly the results of your treatment. Put this in consideration. I'm not saying that open treatment for degenerative scoliosis is the only answer. And Nikolai is not saying that everything can be done minimally invasive, but It's the learning curve and what works well in your hands. And you have to weigh everything related to this patient, especially the balance, and whatever tool that you can use to get this done in your hands, you make it work, because minimally invasive techniques can turn to be maximally invasive techniques if they're not in good hands.
Absolutely, I agree. I agree with you. The bottom line I wanted to just to conclude is that I start with these patients with serial injections, and I try to localize a pain generator, which is I try to localize where is exactly the level that bothers the patient the most, and what exactly is that? Is that radicular pain? Is that back pain? Is it both? And if I manage to localize one or two levels, then I go with that instead of big deformity.
Nikolai,
yes,
I have one question. If there is both sagittal and coronal imbalance, what is your priority to correct? Shall we correct first the kyphotic deformity or scoliotic deformity?
So the literature suggests that if you have scoliotic deformity and if you have kyphotic deformity, the kyphotic deformity is more important for the quality of life of the patient comparing to the scoliotic. So I probably would choose to correct the kyphosis first, and if there is positive sagittal balance.
Is it possible with shorter fixations?
You would not go maximum if it's not major deformity. I would say yes. If it's obviously if you have significant deformity, then the answer is no. But I also would not go full max. You know, if I can achieve some compromise, significant improvement of the patient's symptoms, even though the patient is not fully corrected, and if the patient is okay with that. Of course, there will be symptoms. I will not make the patient symptom-free after the procedure, but I will still try to be as minimalistic as possible.
I'm going to pull chairman's prerogative here to make a couple comments. To Paulo's question about use of laterals, I use laterals for a lot of these patients, but the one thing I'll do if I'm considering a lateral, if you're considering any of the anterior fusions where you're looking to get an indirect decompression, I think it's really important to get a CT scan. Because if you have a patient where the stenosis is predominantly ligamentous and you do an indirect decompression by jacking the disc space up, they will get well decompressed. But if they've got a very calcific stenosis, you won't get the decompression and you'll have to do that. The other, I do a lot of limited surgery for degenerative scoliosis. I do a lot of major deformity surgery. And to me, the question always just comes down to balance. If you have somebody with a balanced spine, look to do something minimal. If you have somebody with an unbalanced spine, I think you're fooling yourself to think you're going to treat this patient if you don't restore balance. And so that's the key as far as I'm concerned. Now,
I agree with that.
I think it's, unfortunately, I'm not sure why, but Rick Fessler from Chicago, who is supposed to give our next talk, does not seem to be available.
He's here.
Oh, he is here?
Yeah, he's here. I've just asked him to unmute him.
Okay. Good morning, Rick.
I'm trying to unmute him.
Okay.
Maybe I'll call him and ask him to unmute him.
Paulo or Nikolai, you can introduce Rick.
Okay, I'm happy to introduce Professor Richard Fessler from Rush University, Chicago. He's gonna talk to us today about minimal invasive correction of degenerative deformity. I think speaking about Professor Fessler and minimal invasive deformity correction is we don't need more presentation than that.
Sorry, Nikolai, I don't see him anymore. He got connected and disconnected, and he's not picking up the phone. Sorry, we can move on.
Okay. Well, in that case, we're gonna go with the next speaker in our meeting today.
Would be me.
Yes.
Yeah. Yes, sir.
Okay. All right, here we go. All right, you can see my screen? Okay, all right, good morning, good morning, good evening, good afternoon, depending on your time zone. Gonna talk a little bit about, do a little bit of a talk on thoracic pedicle traction osteotomy, more a sort of how-to thing. So here's the case. This is a 24-year-old woman. She presents complaining of predominantly axial pain, no radicular symptoms, no weakness. The predominant pain is thoracic, particularly lower thoracic, but with prolonged standing or walking, she's getting low back pain. And if she tries to lie supine, she gets severe cervical and intrascapular pain. She was diagnosed as having Sherman's kyphosis as a 14-year-old. No brace was done at that time. Because she was already skeletally mature, or almost skeletally mature. She was stage 4 risser at time of diagnosis. She has done extensive courses of physical therapy over the intervening 10 years, tried a lot of non-operative therapies, really nothing much working. Clinical exam, she's a slender, healthy looking female. She stands in really marked negative sagittal balance. Which is a little bit unusual. She has an obvious sharp apex to her lower thoracic kyphosis. She has a completely normal neurologic exam. And these are her standing x-rays. And I want you to note particularly, note where her standing sagittal axis is. Here's C2, you take that straight down, and she is about 8 centimeters behind the posterior corner of the sacrum, and she's about 15 centimeters behind the femoral heads. And what's happening, if you look closely, you can see the very severe lumbar foraminal stenosis due to over lordosing. And so she's starting to get some secondary degenerative change in the lumbar spine, although the primary deformities in the thoracic spine. And here you can see her MRI. The first thing to notice in her MRI is how well she actually corrects in terms of the areas above and below this apex. She's almost straight through here, almost straight down here, and the predominant curve is here at the apex. In these Sherman's patients, and particularly as they age, I always feel you should get a CAT scan because many of these patients will go on to spontaneously fuse. And if you're looking at doing a procedure with segmental correction, if they've spontaneously fused anteriorly, you're not going to get any correction. So this is her CT scan. And although she does maintain open discs, she really doesn't correct much across the apex. This is sort of her presentation. So just thinking here in terms of the options and decision-making process at this stage. So she has failed conservative care. She's been trying for about 10 years to manage this non-operatively. She is starting to get secondary degenerative symptoms. So she's starting to get some low back pain. You can see the severe foraminal stenosis she gets when she's standing. She's starting to get some neck pain as well. So the compensatory mechanisms, the hyperlordosis in the cervical and lumbar spines are leading to accelerated degeneration in those areas. And I think if you don't correct the sagittal, the thoracic deformity, those are going to get worse over time. She has a relatively fixed focal kyphosis when she's supine. So she corrects mostly at the levels above and below, but not at the apex of the deformity. So her kyphosis is 85 degrees in the standing position. It reduces to 60 in the supine position. So looking at this, if you're looking at the secondary degenerative changes and the preventing things happening in the future, you probably could get adequate correction in her with just doing multiple posterior column osteotomies at the levels that are mobile. You could probably get her curve down under 50 degrees, which is appropriate for her pelvic incidence, and would prevent some of those other things. This is where sort of a little bit of the nuance and the art of deformity surgery comes into practice, because although you would meet the numeric criteria, you would have a deformity of less than 50 degrees, she would still have this sharp apex. And the sharp apex is noticeable in her when you look at her. And so this is one where we also have to be concerned, particularly in these young women, in many cases, about the cosmetics of the deformity. A lot of us don't think to ask about cosmesis and how people feel about their body shape, but it is really important, and you should take the time to talk to them. And in talking to this young woman, she was very concerned about the cosmetics. And I offered her two options and sort of explained it. I said, we could do the operation that will treat the deformity and prevent some of the longer term degenerative stuff in the cervical and lumbar spines, but it'll be a little more noticeable, or we can do a little bigger procedure with a significantly higher risk, but would get better cosmesis. And in my experience, most people, when offered that choice, will actually take the bigger procedure for the better cosmesis. And so that's what I've elected to do in this case. I elected to do a pedicle subtraction osteotomy. And that's sort of the introduction into the video I'm going to show now. So this is an intraoperative video. It's a different patient than that one. I'm just going to orient things here. The head is towards the bottom of the screen. The feet is towards the top. You can see it's difficult, but because the hose is in the way here, but I've performed, in this particular case, what I do with a thoracic pedicle subtraction osteotomy is I do a full laminectomy of the level I'm operating on, and a laminectomy up to the inferior margin of the pedicles of the level above. This prevents the trailing edge of the upper lamina from folding into the spinal cord when you close the osteotomy. When I'm doing pedicle subtraction osteotomies or any major deformity surgery, I always put all of my screws in prior to doing any of the canal work, for two reasons. One is it drastically minimizes blood loss, is probably the biggest. Get your hardware in when you have a clear field, but also if you get into a point where the patient's coagulopathic and you decide you need to come back another day, if your screws are already in, you can drop a temporary rod in and come back another day. All right, so where are we? Okay, so beginning the video here, and I'll sort of narrate as we go along. I'll stop it occasionally for some points. Okay, here we go. So what you're seeing now is this putter is marking the inferior aspect, or the inferior aspect of the pedicle, and the high-speed burr is being used to come across. And basically what I've done here is I'm basically amputating or removing the facet complex, using the cob and just taking that facet fragment. And then, so the first stage of a pedicle subtraction osteotomy is two-level posterior column osteotomies. And sometimes you'll get lucky and you'll find that, and there goes the superior articular process. And you work back and forth across. Now what's happening is we're skeletonizing the rib. So in order to close a pedicle subtraction osteotomy, you have to remove the rib head for mobilization, but also to allow you to get at the posterior border. So I'm now using the freer to subperiosteally dissect under the rib to remove the rib head. And here you can see just coming across the rib head about a centimeter beyond the tip of the transverse process. And then you resect the transverse process and you come down until you can remove the rib head. And now I'm taking down the pedicle on my side. So I've removed the rib head, and now I'm taking the pedicle down to its base. And you can see my assistant here is holding a pen field to protect the nerve root. In the thoracic spine, I will usually take the nerve root at the level of the osteotomy. Always take it preganglionically to prevent neuroma formation, but it just allows a little better fusion. Now, I just want to stop here. Oh, sorry. Hang on, let me go back. Oh, crap. Sorry. I'm sorry, folks. Let me just want to go. Okay. All right. So what I wanted to point out here, as soon as we get back to this piece, damn, my computer is not being friendly to me today. Okay. Okay. Now, as soon as I start doing my body work, I always make sure that I have a temporary rod. So this is just a piece of rod from the set, but I always want a piece of rod spanning while I'm doing the bony work. Early on in my training, we had a patient where we were doing a pedicle subtraction osteotomy where we forgot to put a temporary rod in. And as we took a bite, we watched the spine shear and the upper portion of the spine dropped about 1.5 centimeters, which was not sort of thing you want to see when you're doing a procedure like that. So always have a temporary rod in, and we'll switch it back and forth as we go. Okay, so now what I'm doing, the bone at the base of the pedicle is really quite firm. So all I'm doing is I'm drilling out that more firm cancellous bone at the base of the pedicle to just get a cavity within the vertebral body to start working. And so this particular procedure, I'm showing a technique called a decancellation osteotomy. So essentially what we're trying to do is remove all the cancellous bone from inside the vertebral body, but at this stage, preserving all the cortex. So we're just using angled curettes to come underneath and to scoop out the bone out of the pedicle and bring it up. And doing it this way, using curettes rather than a drill to do everything, you get a huge amount of bone so that you don't need to think about bone graft augmentation or use of BMP or anything like that. You'll get 250 cc's of bone that you can use for your bone graft. So that's what I'm trying to do here. You'll also notice at the upper margin of this, you can see a piece sticking out. I tend to do all of these procedures under image guidance. I place my screws under image guidance, but I like having the image guidance to guide the osteotomy, to determine where, how deep I am, how far across I am. And so you'll see coming up here in just a minute. Yeah, this is the probe. And all I'm looking at here is, have I resected enough bone superiorly, inferiorly? Am I enough anteriorly? I've changed now from the decancellation osteotomy because we got actually an image guided osteotome. So I actually do a lot more of the procedure now with an osteotome, taking large chunks of bone out rather than the decancellation. But I thought I'd at least show this and then mention the other. And again, you work back and forth to the other side. You can see we put the temporary rod on my side of the procedure, and my assistant's now drilling out his side. Sometimes with a curved rod, you can actually curve the bow of the rod away and leave the temporary rods on both sides. But in this case, we weren't able to do so. And again, just using the curettes and gradually decancellizing all of this. And what you do when you're doing this is you tend to go a little bit at a time. Oh, so what I'm doing now is I'm now going through, taking out the floor of the foramen. So I'm using this 2mm Kerrison rongeur to go. I start at the inferior part of the pedicle hole that I created with my burr, and then I'm just taking this down so that I'm essentially removing the connection with the posterior wall. And again, checking my osteotomy there, checking the depth. And now I'm freeing up the dura from the posterior wall. And now this is a little footed bone tamp. I'm sliding that under the dura onto the posterior wall and just applying ventral pressure. And you see I've just fractured the posterior wall down into the defect we've created. And now to finish my osteotomy, I'm using an osteotome to now just fracture the lateral wall. So what I've changed now is this osteotome is now navigated. And instead of drilling out the base of the pedicle, I just use the osteotome to remove, with the image guidance, to remove the entire lateral wall as on block. Okay, so now what I've done, the osteotomy is complete, and I'm now going to close it. So I just loosen off the top end or the bottom end, just one end of the rods. And then the reduction maneuver is essentially applying ventral pressure to the spine and compressing. So here you go. And I do it just like this. I do it by hand initially. And you get about half of your correction this way. And you can see the spoon retractors that allow me to visualize the lateral wall while I'm doing this. And it also protects in the thoracic spine, it protects the lung. So I'm feeling underneath the dura to make sure there's no tethering, but also that there's no fragments that are preventing me from getting my reduction. And then I'm just using the compressors. And this part of the procedure should take, the closing the osteotomy, I figure should take me 15 to 20 minutes, because you're just going slowly, working back and forth, getting a few millimeters at a time. If you get aggressive, you can pull the screws out, and then you've lost a lot of your corrective ability. So it's really just a matter of releasing the tension. Again, when I'm doing this, the predominant move I'm doing is not the compression, it's applying the ventral pressure to the spine. And again, we just work back and forth across until we get the osteotomy closed down to the point that we want it. Okay. And so that's just sort of how I do a pedicle subtraction osteotomy. So this is the intraoperative film that we got on the woman I showed you. And you can see here, even in the prone position, look at how much room there is, how much more room there is in the lumbar foramina. So I haven't done anything to these foramina other than realign the spine. And here are her x-rays at 3 months out. I always put an extra rod across the pedicle subtraction osteotomy level because there's fairly high pseudoarthrosis rate through them. You can see, I didn't show the immediate postoperative films. The immediate postoperative films, she had gone from 15 centimeters negative positive sagittal balance down to 10. And you can see even here, 3 months out, she still hasn't completely equalized. She's just at the posterior corner of S1. I just saw her again at the 6 month mark, and only now has she rebalanced her spine so that her C2 is directly over her femoral heads. So in summary, in this case, I wanted to use the PSO to get a more physiologic contour to my correction, to get rid of that sharp apex, because I think it improves the cosmesis. And in this young woman's particular case, this is what she really wanted. She wanted this. The pedicle subtraction osteotomy, I think, is an incredibly powerful tool for correction of deformity, but it does have significant risks. Depending on who you read, 1 to 5% major neurologic deficits. And by major neurologic deficits, I mean spinal cord injuries such that at least temporarily they can't walk. And if you ever have one of these, this is so devastating to the patient. So it is something that you shouldn't take on lightly. And also, thoracic pedicle subtraction osteotomies, you should be very facile and comfortable with doing pedicle subtraction osteotomies in the lumbar spine before you contemplate doing them in the thoracic spine. And with that, thank you for your attention.
Great.
Thank you, Doc. Great lecture. I think.
Have we found Rick?
Yes, I was going to ask that. No, okay.
Solomon, have we found Rick?
Nope. Sorry, I tried calling and message, but no answer.
Okay, because I haven't gotten any answers to my messages either.
Let's carry on. Yeah, let's carry on.
All right.
Okay, so let's move to our to our next speaker, and then we'll have the discussion at the end. Next speaker is Professor Onur Yemen from Istanbul, is Associate Professor of Neurosurgery, and is also a member of the WSCS Spine Committee and the Young Neurosurgeons Award Committee. It's a pleasure having you here, Onur, and thank you for sharing your expertise.
Can you hear me? And can you see my screen?
Perfect. Yes.
So first of all, I'd like to thank to all organizing committee for the invitation. World Spine Column Society is really doing a great job. So vertebral column resection, according to Schwab classification, we know that type 1 is Smith-Peterson, type 2 is Ponte, type 3 is pedicle substruction, type 4 is corner osteotomy, and when we come to type 5, this is VCR, and also type 6, if you remove more than one vertebra, it's type 6. As a summary, type 5 and type 6 are the VCRs for according to Schwab classification. So what are the indications for VCR? If you have a rigid kyphosis or scoliosis or kyphoscoliosis cases, that's the angle is greater than 80 degrees, and if the flexibility is less than 25%, if you have a severe angular deformity, if you have a truncal imbalance and hemivertebra, and if you have type 2 coronal malalignment, you may use VCR. So I have get this films to one of my friends. He have drawn me and sent it back. Basically, the vertebra in blue color, you have to remove all of its parts, the whole vertebral body, the anterior part, the pedicles, the posterior part, the disc above the vertebra and the disc below the vertebra. So you remove it, you close the posterior part, you lengthen the anterior part, and my friend told me that it's really a easy technique, but it's not. So VCR is a posterior closing and anterior lengthening osteotomy. So if you're trying to make a thoracic VCR, first of all, you have to need a subperiosteal dissection of the rib here. This is the medial part, the vertebra is here. If you have a spatial dissector like that, you have to put it below the rib here. Then you have to dissect it from the pleura and also from the neurovascular bundle here. If you have ronger, you may use a ronger, but if you don't, if you have a spatial rib cutter like that, you may use a rib cutter. We cut it from the proximal part, from the medial part. You may use a gauze to prevent the pleura and also the neurovascular bundle here. Then you go to laterally. 5 centimeter will allow you to see the lateral part of the vertebral body there. So you may use that grip as a graft after the surgery. Now a transverse process and also the proximal part of the rib hump. The rib is here, so you have to remove it. This is, I exactly don't have a full VCR video, so I made a mix here. This is the lumbar area. First of all, you have to make a laminectomy here. You have to see the pedicles, you see the foramens here. So there's a technique that you can go inside the vertebral body after making the laminectomy, but some surgeons prefer to go directly to the vertebral body. They say that the advantage of their technique, going directly to the vertebral body, is less bleeding. So the technique that I'm using, I have to see the spinal cord, then I remove the lamina, I remove the pedicles here. So with an impactor, you have to draw the posterior part of the vertebral body here. The things that we can say here is, first of all, it's bleeding too much. Then we can use Flucil, Surgicel, gel foam, and you can put gauze in it. And another technique, another trick here is don't try to work always on the same side. So let it to stop the bleeding from one side, go to the other side, so that you can decrease your bleeding there. So then you finish to remove the whole vertebral body and also the disc above the vertebra and the disc below the vertebra. You have to close the posterior parts. Doing all the maneuvers on a permanent rod will increase your risk of the screw loosening here. Another technique here, if you make a VCR at that segment, you put 3 screws above and 2 screws below the VCR. You put a temporary rod here, another temporary rod here. So you use a third rod on the lateral of the 2 temporary rods here. You put a domino here and also 1 domino here, so that you can make the maneuvers on the temporary rod here. It will allow you to decrease the risk of the screw loosening here. So the first maneuver that you have to do here is to close the posterior part, but it's an posterior closing plus anterior opening. So you have to do the posterior closing first. Then to open the anterior part, you may use inside to rod maneuver on the temporary rod here. Doing this maneuvers, you always have to put a rod on one side to prevent the spinal cord translation here. And during this maneuvers, when you're doing it, you have to always control the neuromonitoring. If you have any problem during the surgery, you have to correct that maneuver that you have done in the previous step. So after that, I finished my presentation. We may talk, but we have to do if you lose the neuromonitoring signals during the surgery. So if it's possible, try to keep the both inside of the vertebral, the part that you have made osteotomy, try to bring it together so that you can get a better fusion surgery. And after removing the rib, you may insert it between the laminas and also the spinal process and the middle of the rod here to get a better fusion. For the keynotes for VCR, do the compression first, use temporary rods for the maneuvers. If you can use osteotomes, it will be helpful for you for less bleeding. Avoid over-shortening, take care for the dura for buckling, check the neuromonitoring. So these are the case examples. This case was 48 years old, has a progressive weakness in the legs. You see there's an angular kyphosis here. So the scoliosis graphs were not good, but our plan was making a VCR here. So we put a cage anterior, we shortened the posterior segments here. Before and after surgery. The image of the patient after surgery. Another case, again, there is a thoracolumbar kyphosis here. The patient has a progressive kyphosis difficulty during walking and had a previous tetrate cord operation. The scoliosis graph, CT and MRI image. So we planned a VCR surgery before and after. And this case was a lumbar degenerative scoliosis case. At the beginning, we didn't plan in a VCR, but the situation brought us to a VCR. We had planned to make a pedicle substruction osteotomy here at L3 level. Then in 6 months, the patient gets an infection, then thromboemboli, screw loosening, and this is the 5th surgery that we have done. So to take a message from these osteotomies, especially 3-column osteotomies, you may have too much complications. So if you look to the literature, this is a good review paper from Young. They have summarized 7 studies. You see the VCRs have 30% complications, the surgery time, the bleeding. Most of their complications in this paper were neurological deficits. These were the papers that they have summarized. nerve root injury, spinal cord injury, bowel and bladder disturbance. Another review study from Ha and their friends, they have checked the neurological complications. It differs from 2% to 18%. Another comparing study with retrospective and prospective comparison study, the neurological deficits were 17 and 9%. Another study, 2% permanent neurological deficits and 20% intraoperative monitoring changes. So we have learned lots of from these papers, and this girl was 17 years old. You see the severe kyphosis here. We have told all the complications before the surgery. They have accepted the surgery. You see the 3D CT of the patient, a severe upper thoracal kyphosis and also scoliosis. You see how the upper thoracal spine has been deformed like this. So we get a 3D model so that you can see the ribs here, so that you can decide which part you have to perform a VCR osteotomy. We get this patient. This was not that girl's video, but we get this patient for 2 months a hollow traction. But before the surgery, the patient had abandoned the surgery, so we couldn't do the surgery. So the first that I can say at the end, if you can correct the spine, if it's possible, these are the cases that we have operated and could correct it without VCR, and also this one. The complication rate for VCR is too high. You may use it in selective cases. Do your maneuvers on temporary roads, control the bleeding, and check your neuromonitoring during the surgery, because in the surgery, if you have lose your MIPS, the motor evoked potentials, you're asking yourself, what am I doing here? Do I need to really do the VCR? What am I going to do now? Yes, we know what we have to do, but if it not comes back, you get very excited, depressed during the surgery. And another thing is, I think, have to be the or talk about the previous examinations or your things that you have lived during the surgery. Doc, did you get my question or my expression? Thank you so much for listening. These are the things that I want to say. So, yes. Talking between each other, okay, maybe we have to talk. I'm sure every surgeon, every deformity surgeon who is doing these surgeries have felt like me. Then you lose it. You're saying that, what am I doing here? Do I really need a VTR? Why I'm not in a disc surgery? Why I'm not doing an anterior cervical discectomy? So you get depressed, and something, a cascade starts there. Yeah, we know we have to control the blood pressure, the temperature of the patient, the hematocrit, yes. But what do you feel during the surgery when you have something like that? Is the answer we don't feel anything? No. We're professions, or something happens there. Yeah. You say that, why I'm not a tree in a mountain? Why I'm not a stone in a mountain? Why I'm looking here? What I'm doing here? Thank you so much for listening.
Thank you, Onur.
Thank you, Onur. Very interesting talks we had. I think Rick Fester did not arrive, so then I will call Dr. Richard Assaker, a good friend of us. He's the professor of neurosurgery in Hospital Salengro, Lille, France. He's a really very well-known deformity surgeon, spine surgeon, we will be happy to hear Richard's talk on traumatic deformity, anterior release, and percutaneous screws.
Thank you, Mehmet, and hello, everybody. Just I would start by answering Honor about his conception of this hard work. Make it, share it with another senior surgeon. This is the best you can do. This is now routinely we're doing this to seniors, and so you split by 2 your stress. Okay, let me share my my screen. I think somebody has to give me the right to share now. Yeah, here we are.
It's open, yeah.
Okay, yeah. So this is my topic is about post-traumatic deformity, how I deal with this, and I focused on pearls from the OR, but I voluntarily get some pearls pre-OR and post-OR. So to make your OR effective, you need to think first, and you need to manage your complication and manage your follow-up. So post-traumatic deformity is not so rare, and mainly it's a kyphosis deformity, which is easy to solve compared to what you showed us till now. The causes are clearly inadequate primary treatment. So if you neglect alignment during your primary traumatic surgery, it might end up with a symptomatic sagittal deformity that could be very annoying. Could be also the cause of pseudarthrosis or a hardware failure. So let's start with the pre-OR. Before going to surgery, what should the surgeon knows? He should understand the physiopathology, because patients comes to you actually not for focal pain. It's rare to come for some thoracolumbar. Doug told us today, my talks is similar to his thoracic thoracolumbar kyphosis. Mine is traumatic, and the topic of Doug was degenerative or Scheuermann disease. So it's rare to have focal pain from the site of the surgery. It's mainly they come to you years later for lumbosacral pain, and this is due to compensatory mechanism. As a start, you have two different populations. People with a high pelvic incidence, like incidence B here on the right side of your screen, tolerate a post-traumatic kyphosis. The people with a low incidence pelvic incidence does not tolerate, and those patients come back to you for lumbosacral pain after post-traumatic kyphosis. So this is actually your trauma, and you can see there is a broken screw here. This was, I would say, 7 years after surgery, and patient had many surgeries, hardware failure, revision, taking out the hardware. And actually you have to think globally. You have to get your full spine x-rays, and we are repeating the same things, but it's helpful to know that you should think on the full spine and not on regional spine. And if you look carefully to your spine, and this patient comes to us for lumbosacral pain, and the rheumatologist sent her for discogenic back pain at the lower back, and he was expecting some kind of treatment on the lumbosacral area. If you look carefully, you have, as Doug says earlier, lumbar hyperextension. This is a compensation. You have thoracic hypokyphosis. It's also a compensation, and you have retropelvic retroversion of your pelvis. So all those mechanisms are compensatory mechanism from the thoracolumbar kyphosis. And when it comes to patient with a low pelvic incidence, it's not tolerated, and patients come to you for pain. Sorry. So planning the treatment, we still not in the OR. Planning the treatment is as easy as any. I don't have a planning for a specific post-traumatic kyphosis, but we know today that we have lots of software that allows us to simulate osteotomies, posterior or pedicle osteotomies, and we can, in a real time, see virtually what's going on. If you perform an osteotomy at one level, you can see the whole spine adapt to this new osteotomy, to this new geometry. So we can plan our surgery ahead. And this is an example of flat back syndrome here, and we simulate the surgery and we mimic our simulation during surgery. So I will not focus on this, but this is what we've done after the surgery on the left side. So as any deformity surgery, you can simulate before surgery. So we're still not in the OR. In a situation like post-traumatic kyphosis, the aim would be to get back to a physiological regional angles endothoracic, endothoracolumbar junction. So it's well known what would be the regional angle between T12 to L2 or L1, etc., etc. So make sure that your aim is to restore the physiological thoracolumbar angles. So we still not in the OR, and this is an important point because you have to inform your patient about your plan. And the patient would be, he's coming to you for pain located at the lumbosacral area. And what you're telling him is you will treat the old kyphosis that is there for years. So you have to explain to him why is this, why you are treating the high part of his spine to cure the lower part of his spine. And this is, I'm not underestimating this part of the consent and of the information for your patient. So make sure that the patient understand why you're working down to, and it might be more tricky than this. If, for example, he had, I don't know, some deformity on the cervical spine and you're treating the lumbar spine, it's not easy to let your patient understand what you're doing. Now let's go to the OR. So, and I would go through examples of treating those patients, and I will focus on tips and tricks. Prior to surgery, I mean, in the OR, you have to be able to do osteotomies, of course, from simple PCO to PSO and to VCR, like Honor showed us. Also, it's nice to master the eggshell technique, because the eggshell technique in the thoracolumbar area is safer than taking out the whole pedicles. It's mandatory to have your neuromonitoring. You cannot close an osteotomy site on the thoracolumbar area where the cord is there without making sure that you are safe and you are monitoring all the functionality of the cord. And you should be able to control intraoperatively, and I'll show you a case what you're doing. So let me show you a very difficult case to treat. This lady, she's only 39 years old. She had a history of T12 fracture 4 years before referral to us. And she had two surgeries. One was a primary surgery, and the second one was hardware failure and removal of the material. And she came to us for lower back pain. Of course, you can see here, you have a black disc. She had a proposal from other surgeon to do a disc prosthesis at level. I don't know if it's a right solution, but the patient, she's complaining of the whole lower back is aching, plus some trouble in cosmesis because she's falling down. She's a cute lady. She's 39 years old. So as a principle, of course, you're looking locally, but you have to think globally and look at this patient globally speaking. She had a hyperkyphosis at the thoracolumbar area, and she had a low pelvic incidence, and she's mismatching with her lumbar lordosis, which is overestimated. I mean, the lumbar lordosis is too much according to her pelvic incidence. And you can see that this might affect her lower back. And she was treated 4 years before, so degeneration is still reversible at the lower part of her spine. So I spent some time explaining to this patient why I would not address L5S1 disc and why I would go for the T12 fracture to restore normal alignment. This is her X-rays on hyperextension, and you can see that like usual, the deformity is a rigid deformity. So what I've done here is eggshell technique. So I empty through the pedicle the body of the vertebra below the end plates, and I close the level. So this is intraoperative control. You can see that below the end plates, we shorten the posterior column and we close it intraoperatively. And this is a fluoroscope 3D intraoperatively showing that I came from kyphosis to almost a 0 degree at T12. This is a post-op, and this is the final result after the surgery. So look, this is her, look at the lumbar area here, look before and after. So you can see obviously you realign, and look at the thoracic area also, it's probably all went back to normal alignment after correcting this kyphosis at the T12 level. Another example here, same story. A patient had, you can see the screws left there after, I don't know, 3 or 4 surgeries for inadequate trauma at the beginning. And this is a post-op. Here in this situation, we've done like honor, we've done a VCR, and you can see that we place a cage anteriorly just to make the hinge more posterior in order not to shrink or kink the cord. So this is before and this is after. And again, look at the lumbosacral area, it decrease in lordosis. More complicated one, it's a true failure of trauma treated posterior and anterior. In this situation, you have to remove the whole hardware here and then go back to VCR and correction from posterior. So now, till now is a simple and straightforward surgery. What about doing something more elegantly, and what about minimal invasive options? Let me show you this case. This is a 54-year-old lady, L1 fracture, pseudarthrosis, hardware, and end up with non-union, with thoracolumbar rigid kyphosis. ODI was 46. And this is the regional x-rays here. And as the other cases, I plan to go and reduce this kyphosis here. What I've done is placed all my screws percutaneously, above and below the level, 2 above, 2 below. And I just opened, I've done open surgery with a retractor that I placed laterally. So from lateral to lateral, an expandable retractor exposed from transverse to transverse, left transverse to right transverse process. And then I start my osteotomy and I linked the extenders together. Let me show it you in operating. So the osteotomy is done in a mini open way, and my screws percutaneous above and below was rigidly fixed longitudinally and transversally. So I had a multi-level fixation, multi-pedicle anchor to the spine, and I can manipulate my spine in caudal to rostral, in caudal to cranial pieces. And what I've done here, you can see here, we will close gradually under C-arm, closing gradually the osteotomy site in a safe way, because the whole spine is quadralized and is stabilized by this frame. So it could be done also in open manner, but here is the control, and it end up, you can see this is before and this is after the osteotomy done minimally invasively. So before and after, before and after. And you can see also all the compensatory mechanism disappear. Now the last pearls. It's an easy surgery. It might be easy surgery during surgery, but it's a long story, actually. You have to keep following your patients. Look at this example. This is a recent example. In August 2012, this patient comes to us with post-traumatic kyphosis. But you will see later on that this trauma occurred on a patient who had some potential deformity. So we've done the first surgery, like I showed you, and this is a nice result. In January 2012, I was happy and ready to not follow this patient. And this is the post-op here, before and after. It's nice. I can it can be part of my so-called success results. She came. She came to us in June 2012, starting having some kind of discomfort, and the patient was still okay on the full spine X-rays. September 2012, the fusion. I assessed the fusion was good, anterior and posterior. I said to the patient, you know, you have to go to physiotherapy and let's follow you. June 2013. Start to have some thoracic pain with some kyphosis at that level. December 2014, look at the lumbar area, start to be in kyphosis also. And I assess the lumbar area, just a non-specific black discs, but she's complaining more and more. This was in March 2015. In December 2015, she's having unbearable pain on both junction and on the thoracic and lumbar, but predominantly on the lumbar. This was her thoracic problems. This was the lumbar pain, and you can see there is a significant kyphosis despite a good surgery, because look, the rods are short. I did not exceed my laminectomy to this level, etc., etc. So everything was at least apparently fine, but the patient dislocated the lower below. So I went anterior in May 2016. I said I will correct the anterior. Maybe she will be happy, and just make it anterior pre-psoatic access to L3-4, L4, L5. And this is a post-op here in May 2016. June 2017, everything is okay, but still complaining of her thoracic area. And I've assessed all the area, the disc at L5S1 still okay. And this is in January 2018, falling down anteriorly gradually, and miserable life. And okay, you have to explain to her what's happening to her. January 2018, I will not go through videos here because we don't have time. And finally, at May 2019, complete anterior shift, despite fusion is good, no true adjacent level failure, but it's a regional failure. And this is, you can see here, at that time. I again assessed my fusion. It was okay, and I had to go from look here. In February 2020, I went to the sacrum here with multi screw fixation, and I went to the thoracic till T3. And you can see my technique here is dominoes. So I went to the cranial and caudal and just extend my fixation without opening the whole area, which is less aggressive than. And now this is, you imagine, 2011, just a post-traumatic deformity, 2021, a full spine fixation. So this is a long story. Fortunately, and as Honor says, why I treated this patient from the beginning. The message, the posteriorly based osteotomy has to be mastered, and especially all the variation of this for this sagittal, I would say, experimental deformity. And also, do not think locally. Look locally, but think globally. And it's important also to make sure that your posterior colon osteotomy is done under neuromonitoring, and you're not shortening. This is why in some cases you have to put a cage anterior. As a prevention, think to align your patient from the start, which is very easy. And when you have patients like this, do not hesitate to go anterior and make sure that your structural support is effective and do not lead to any of the kyphosis. Thank you very much. And I can answer your question if there is any.
Thanks a lot, Richard. Very nice lecture. I will give Paolo to, let's make a discussion now or after the last talk. What do you think? Pedro Berjano has also one talk.
So maybe let's get that talk and then have the discussion at the end.
That would be nicer.
Yeah. Okay. So then we'll discuss everything together.
Yes.
So Nikolai, do you want to present Pedro, please?
Yes. So next speaker that we have today.
Sorry, we need to get Richard to stop sharing. Good. Okay, sorry. Go ahead.
Thank you.
Right. So next speaker that we have is Pedro Belgiano, who is going to talk today about corner osteotomy for sagittal deformity. Please, Pedro, do you want to go ahead?
Thank you very much, Nikolai. And thank you all for inviting me to this interesting session. So I will try to keep it relaxed, not to make a massive presentation, just to have you with some sugar in mouth. This is the team I have the privilege to lead, and that supports all the work that I'm going to present. And these are my disclosures. And I will start with this case. This is a common degenerative spine deformity. It's just sagittal, and it's quite a rigid spine. And as you can see, she has a relatively high pelvic incidence, 63 degrees. She has no lumbar lordosis. It's actually 1 degree of kyphosis, a huge pelvic tilt to compensate for this, and she doesn't have any compensation in the thoracic spine. So I think that all of you would agree that this patient, if we want to pursue a solution, needs to support all the thoracic lumbar spine to the pelvis and to increase the lumbar lordosis. And here there is a debate, and our position, our group, usually tends to prefer correcting to normative values, though the patient is elderly. And this can be a subject of debate. What we try by all means is not to overcorrect. regarding or compared to the normative value. So in this patient, my calculations were that 65 degrees of correction would be required. And if you go to the literature, you see that pedicle subtraction osteotomy in its standard flavor gives you a correction of about 20, 25, sometimes 30 degrees, but it's difficult to obtain more than that. And that's because of the geometry. Usually the limiting factor for a PSO is the height of the posterior wall that you can resect, because below this lower blue line, you have the exiting lower roots, and it's difficult to cut under them. And superiorly, you have the disc, and you can include that, but at the end, more or less the maximum correction that you can have with an intraosseous PSO is about 30 and sometimes 40 degrees. But in some patients, you need more of an acute correction. So the idea of corner osteotomy is to change the shape, and it's shortening the length of the osteotomy. So finishing not at the anterior wall, but making the fulcrum at more or less 2/3 of the length of the disc, and to include the discs into the osteotomy. And by doing this, you change the maximum angulation you can get. And it's easy to get 40 degrees, but it's also possible to get as much as 70 degrees, because this is actually a closing, posteriorly closing, anteriorly open osteotomy. Now, if you shorten too much the length of the vertebral body resected, the length of the corner, then the difficulty is to close the osteotomy in a geometrically sound way. So you have to, I think that 2/3 of the length of the rig of the disc is going to do the job very well in most cases. And this the schema of what you do. You resect the corner, that's the reason of the name. Then you close the osteotomy, and the final ingredient is to put a cage. Usually we do this after we have closed the system with screws and rods, and then we push upwards this floating body with a cage placed laterally. In the last years, we're doing this in prone position at the end of the surgery. Here you have the example of this lady. You can see at the end of the closure of the osteotomy with the rods in place, you have some space between the upper disc and the osteotomized vertebra. But after placing the cage, and I'm sorry because this picture is a little bit pixelized, but you have full contact. And this is because the X-lift cage is going to push up the vertebral body, which is actually floating. This is the correction that we had with this lady. And as you can see, all the parameters were corrected to normative values, not to elderly values. And she was very happy. She was doing well. Here you can see the CT scan 1 year after the surgery, and you can see how bone has healed at the site of the osteotomy, and is beginning to heal through the cage. And that's a substantial advantage because you can have a consolidation of the anterior column. This is a cadaveric example. We first empty the disc above the osteotomized vertebra, and we prepare the inferior end plate for fusion. And then if you have one instrument into the disc, you can very easily calculate the angle that you are going to correct. Here you see in the lower part the intraoperative C-arm views of the osteotome before and after resection of the wedge. And in this video, you can see some of the detail. This video you can see in open operating theater, and you can see the full version with all the explanations. And you can see how, again, we have first prepared the disc space, then now we are working on the left of the patient, resecting. This was a very hard bone for a cadaveric specimen. And we first removed 2 wedges at the sides around the pedicles, and then we undermine the vertebral body in the area of the dural sac. There you can see the removal. You can do some more disc preparation after after this. Of course, we are very brave here because this patient is not going to survive the surgery. But in normal patients, we take much more caution doing this, as you will see later. So something which is important, I'm an orthopedic surgeon, and when I did knee osteotomies or tibial osteotomies, I was very careful about the shape of the osteotomy because it's what is going to cause congruity, stability at the osteotomy, and fusion. And we do the same here. We try to have a very flat surface of osteotomy, which is congruent from the right to the left side. And that helps a lot to close efficiently the osteotomy. Sometimes we use an osteotome to remove some of the lower end plate of the upper vertebra, and that gives you some extra degrees, and that gives you some fresh bone to close the osteotomy. And very important, we try not to resect too much of the posterior column, because one of the elements of stability and of fusion is to get posterior contact. We have exaggerated here by not removing the spinous processes, but as you can see, when you get posterior contact, you have more chances of having a posterior fusion. That's good for the patient. So these are the surgical steps. First, you make your posterior column planned resection, not any resection, not as much as you can, but only the amount you need. Then you free the 4 roots completely and the dura. Third step is to remove the disc above and prepare the end plate for fusion. So we are delaying the parts of the surgery that are going to bleed more. We first do the things that are bloodless. Then we cut the base of the transverse process of the vertebra we are going to osteotomize, and we dissect the lateral wall as Doug has been showing in his video, and as Honor has been showing. Then we cut laterally the disc, and this is very important because by doing this, you make sure that you will be able to remove the wedge of the vertebra you are cutting. Otherwise, the disc is going to impede you, to prevent you from removing this. Then we resect the lateral wedges, and we make sure that this, by protecting the lateral walls with spoon retractors, we make sure that we resect the lateral wall, because this is what more frequently impedes you closing the osteotomy. Then we undermine the posterior wall, maintaining the shape of the osteotomy plane, and then we implode the posterior wall below the dura, as it has been shown. There you see the anatomy, and I want to show you the dotted black lines that tell you where you have to cut the disc, also below the dura, and then laterally going caudally. And I'm sorry, and we protect this. This is a Penfield retractor that is around the disc, inferior to the exiting root. That makes you comfortable with this cut and avoids any risk of damage of the exiting root here. So I will show you one application of this corner osteotomy in a much more complex case. This is a 65-year-old lady who was after 7 surgeries in this condition. She had pain, she had this deformity, and as you can see in the CT scan, this was not correctable in supine position. Actually, he could not lay down supine. But if you want to see the real deformity of this patient, and I learned this from Richard's former partner from Daniel Chupin, if you want to know what is the real deformity, you have to normalize the pelvic tilt. So you have to tilt the image and show the patient with the normative pelvic tilt for his or her pelvic incidence. And here you can see the huge deformity. So this patient in our plans would need twice a 60-degree PSO, which is complex surgery. And you can understand that when you see the patient placed in prone position. It was almost impossible to free the abdomen of the patient. And this is after the first procedure. In this procedure, we were doing this PSO, and we had to stop. We had to stop after the patient was bleeding 8 liters. So the pressure of the abdomen made it impossible until the closure of the first osteotomy to go forward. So at the end of this osteotomy, you have to stop the surgery and take it over some months later. So the plan for the correction was this one. Again, with the normalized pelvic tilt, you can see how much correction you need to keep the patient straight. And we did some geometrical calculations on the CT scan just to measure how much posterior wall resection we needed and how many degrees of angulation we needed. This is the patient place for the surgery. This is the identification of the right L4 pedicle. And here we start with these sophisticated navigation tools, which is a pen and a ruler. We mark the beginning of this osteotomy, the posterior wall resection. And I repeat, this is for letting the spine to touch posteriorly at the end of the closure. So you will see that we do this with osteotomes. Nowadays, I prefer starting this with a bar because this is going to reduce the bleeding. And I try to get parallel to these templates with an osteotomy above, one osteotomy below. And yes, you can remove very well a pretty large amount of bone doing this. And this avoids you a lot of handwork with the carries and rongeurs, which is something tiring and not very ergonomical. And when you are in your 50s, you begin to feel that in your hands at the end of the day. So now I'm resecting the isthmus part of the vertebra. There is a pedicle in the middle. Of course, we have a very stringent protocol of neuromonitoring. The neurophysiologist is controlling very frequently during these moments of the surgery, during these steps. And you see that I try to keep two planes of osteotomy as I would in a tibial osteotomy. I try to do two matching ramps at each side of the osteotomy just to make them touch and to have a large surface of contact. Now I direct laterally. I always take the pedicles as references for these maneuvers. You can see how much bone you have to resect before you go to the dura. And then we start some more delicate work. I try to avoid dural tears in these cases because, dural tears are something you don't want here because they are going to take time and take stress from the team. So I'm very careful about this. And here you can see now we are starting to have freed the spine. It's a large angulation we have to obtain, so it's a large resection posteriorly, like 5 millimeters. Usually in corner osteotomy, 1 millimeter corresponds to slightly more than 1 degree of correction. Okay, now we are going laterally below the pedicle and above the pedicle, so we try to leave the pedicle isolated and showing the roots. Today, I would be much more careful about bleeding. I would be putting some Surgiflow or Flow Seal here. I would be putting sponges every time, taking more time, because at the end, in the last 1 or 2 hours of the surgery, you avoid having to run to finish your surgery. Now, here you can see the disc above, you can see the root above on the right side. And we try to very careful undermine the osteotomy planes just to avoid that the dura becomes kinked when we close the osteotomy. This is very important to make sure that when you close the osteotomy, everything is going to go smooth. Now this is the pedicle again. Both roots have been freed around the pedicle. And here you see this spoon retractor after we did the osteotomy of the transverse process, and we did the dissection of the lateral wall with 1 finger or with a cob retractor. Now we remove the pedicle as had been shown before, all around protecting with the aspiration and with the pen filler. And now in the right side the same, we try to undermine very well so that when this osteotomy closes, you don't have any compression of the roots. If you are very worried about the compression of the roots at the closure of the osteotomy, you can leave more contact in the midline and being more generous on the size of the osteotomy regarding the resection and the exposure. Okay, as you see, we are very meticulous in making sure that we don't have any compression or something that when the spine rotates is going to cause the compression of the roots. Now you can see that the spine is beginning to move. That means that you have released the posterior column. When you do this surgery, controlling bleeding is very important because if the patient is bleeding too much, you are going to lose the potentials at the time of the closure. And that sometimes doesn't mean neurological damage, but it's going to make you worry and make you feel the onerous way, and it's going to prevent you from being calm and concentrated during the surgery. So controlling temperature and bleeding is very important. Now here you can see we are completing the osteotomy starting at the lower end of the pedicle. We do this with an osteotome. We prefer this to ultrasound scalpels because these cause more bone necrosis and you can have more problems for healing of the bone. You see some rest of the disc above. You see a very nice bleeding surface on the end plate of the upper vertebra. And here is when you undermine the bone below the dura, you have to be very careful to avoid to do a parallel resection. You have to keep the angulation of the plane of the osteotomy. Now we proceed on the opposite side, again with osteotomes. We take a lot of effort to be sure that we resect the lateral wall, as I said, because it's going to prevent you from closing the osteotomy. Now I cut parallel to the dura, medial to the pedicle, and before closing the osteotomy, we start putting some graft in the osteotomy site, especially in the anterior part. It's going to help healing, it's going to help creating an anterior fulcrum for the closure of the osteotomy. Here you don't see any temporary rod, but I agree with my colleagues, having a temporary rod is something that you wish, and nowadays we use it in each patient. And finally, the closure of the osteotomy, again, pushing the patient, if the patient is in a Jackson frame, pushing the osteotomy or even closing the Jackson frame in lordosis is just going to give you the correction. My preferred method is having the anesthesiologist using the remote of the Jackson bed and of the proaxis bed and having the patient correcting. And that is also because at the moment of closure of the osteotomy, instability, hemodynamic instability can happen. So the anesthesiologist makes the correction, he or she can stop and reverse it when needed. You can take, you are working with better coordination with them. There you can see a temporary rod, but usually now I prefer using it earlier in my correction. Sometimes I use the domino technique that I will show you to improve the closure. You see that above, as Honor was mentioning, we have already the dominoes prepared for the final closure of the osteotomy. Here you can see the contact of bone posteriorly. That's the nice thing. When I do this, I'm very sure that it's going to heal over time. And now you can see I have secured the rod distally to the osteotomy and not proximally to the osteotomy. And then I compress through the domino. And that's going to help the final fine-tuning of your osteotomy closure. I think that's a very valuable technique. Anytime I can use it, I prefer it. You can see all the amount of bone graft we have used. We get a lot from this osteotomy. And then we finalize the procedure by using two additional rods in a configuration that we call delta rod. We have tested this in finite element models, and this is probably the strongest configuration. And this is probably the configuration that gives you a smaller chance of having a rod breakage. And if the rod breaks, as the accumulation of stress is around the connector, it doesn't break in the critical part of the osteotomy. So I think there are many advantages to the use of this delta rod configuration. Here you see some powder of vancomycin on the rods, and this is the final result on this lady, before and after. And also it's important to see the clinical result. This the same lady walking some 8 months after this surgery. You can see the dramatic difference. It has been dramatic surgery twice. It's a dramatic difference. This lady has a life again. Can go out with her family without a wheelchair. You can lay down in the bed. You can have some familiar and social life, which is something. So in summary, I like to remind you that corner osteotomy is a sexy name for just a modification of PSO that takes advantage of better geometry to provide more correction at one level. And it's a double-edged knife. You can have too much correction if you don't plan it carefully. And it has the additional advantage that it improves anterior column fusion, which is a value also for the durability of the implant. That's everything from my side. Thank you very much for your attention, guys. I think we can proceed with the discussion.
Great talk, really. Thank you, Pedro. Great talk.
Okay.
Are there questions?
One of the questions that came up that I had did a text response to, but I think is worth discussing, is what do you do if you're doing an osteotomy and you lose potentials? I'll sort of say what we do and give the other speakers their chance. One of the things, and I'll credit Sig Bervin and the people at UC San Francisco for this. They started doing this, and this is what we have. We actually have pre-printed sheets in our OR. They're on plasticized cards, and this is the protocol we go through if we lose potentials. So you start talking to, first you start with your techs. Is this potentially a technical problem with the monitoring? Did a wire come loose or something? Second, anesthesia. What's going on with body temperature? What's going on with the blood pressure? Did they recently make any changes to the anesthesia? So you go and then you look at, okay, what were we doing at the time of the surgery? If you've just done a corrective maneuver, undo the corrective maneuver. And so, but by having a written checklist in the OR, you know what you're doing, you go through it, and that way you're not going to miss anything. You're not going to sit there, 15 minutes with the potentials out and realize, oh, the mean arterial pressure is 50. Have that checklist there and go through that checklist anytime it happens.
If I may, Doug, I completely agree with you, but I would say even more. So your checklist of anesthesia, potentials, surgery, it's very good to check if something happens. But I think that before that, and we have been working a lot on this, is keeping a good logbook of what is happening during the surgery. So we do very frequent checks and timeouts about temperature of the patient, blood loss, blood pressure, and we check every 5 minutes the evoked potentials. And that's because some years ago, we used to do only point checks of potentials. And when you do a new check of the potentials 4 hours later, after 2 liters of blood loss, you have something that doesn't work, but you cannot isolate the problem. That's something that you
Agreed.
want to avoid.
Yeah, we have a 5 minute. Our techs are instructed to say every 5 minutes. You know, I mean, not during the exposure, but once we get into the main part of the procedure, they're instructed to remind us every 5 minutes to shoot another set of motors.
Yeah. In our hospital, doing also during the exposure has shown a lot of value, because sometimes you leave the fellow doing the exposure and then the patient is going to blood loss. We try to avoid this though,
Yeah.
but sometimes it's happening, and even during the exposure, you want to have a logbook of what happens.
Pedro, are you doing that corner osteotomy also in the thoracic levels, only in lumbar area?
Yeah, you can do that also in the thoracic spine. In this patient, we did it in both regions. Of course, if you are going to do that in T5, it's a tiny vertebra, it's difficult to do that, and probably it's better to do some kind of vertebral column decancellation or VCR if you want to have a large correction. But if you are going to do that in T10 or T12, of course, you can do corner too.
I got scared when you were using osteotome during removing of the pedicle.
Me too.
Go ahead, Honor.
Something?
Yes, go ahead, Honor.
I'd like to thank lots of people here. I've learned lots of from Aseker, from Beriano, from Doug, from Pedro. The technique that's the corner osteotomy I've learned from Beriano. It's really a good, strong correction maneuver. And I have also learned the delta rod maneuver there. It's also very useful to correct the coronal balance there. The thing that I'm doing during the surgery when neuromonitoring has decreased, first I start praying. Then I try to give some orders, and I hope nobody will leave that situation in the operation room. Really, it's very, at the beginning of my talk, I said that it's really a difficult position for you and for your patient. And I would like to ask Doug, what is he doing during the surgery if something happens?
So basically what happens is that you know, the scrub nerve.
No, the way of you thinking there. Now we know that. Give the orders, check the blood pressure.
The biggest thing I'm trying to think of is there something that I have done that is potentially reversible? So, you know, if I have just closed the osteotomy and we lose the potentials, I take half the correction off and wait and see, you know, if by undoing something I can reverse it. You know, so that's the big thing I think is just sitting there going, okay, what is going on right now, and is there anything I can do to reverse something that has just changed?
And I don't know if you agreed, guys, but I think that having also the discipline to reverse everything that you have done that potentially leads to the problem, and to correctly interpret, to avoid your cognitive bias interpreting the situation. For example, as every patient is going to lose blood, when you lose the potentials, you say, I did nothing wrong, it is the patient. And this is wrong. So I think that when you lose maybe some of the quadriceps one side, that can be okay, and you want to check the root. But if you lose all the potentials in one leg, then that is a problem. That is a true problem. If you lose everything, that is a true problem. And I remember 2 cases very recently from which I learned a lot. First case is a congenital scoliosis. I place the screws, you know, with those custom-made guides that bring your drill exactly in the pedicle. You don't miss one pedicle. And I do this. The patient, before any correction, loses the potentials, and I say, okay, the screws are okay. It's not going to be that. We do everything. We reverse the loss of blood pressure. We put more blood to the patient, etc. Nothing changes. I remove the screws. The potentials return. Don't ask me why. I go to the CT scan, and every track was correct. maybe I inflated one pedicle on the side of the concavity and that went to hit the spinal cord. I don't know, but in that case, I'm happy that I removed the screws. Second case, I do some correction of a very large scoliosis, and I use sublaminar bands in the concavity of the apex. I have never seen one problem with sublaminar bands. So when this lady has a loss of potentials, I remove a screw, I remove another screw, I didn't have any correction, so I think it is the patient. And then I remove one sublaminar band and everything returns. So avoid your cognitive bias, reverse everything with discipline, because sometimes it's going to save a patient from becoming paraplegic.
And to echo that, one of the hardest things to admit to do is to open up an osteotomy again, because you got it, it's closed, you think you're great. It's really hard to open up that osteotomy again. But the one thing I'll tell you is that open it up, get the potentials back. And what I have done on one occasion where that happened is, it was as many of these things, it was a combination of coagulopathy, low blood pressure, blood loss, all of that combined with my corrective maneuver. So what I did in that patient is I talked to the patient, and 10 days later brought the patient back where under in much better condition, because everything was done. And then using the monitoring again, I got my correction back. So once you've settled everything else out, it is sometimes possible to go back, get the correction you took out, still accomplish the goals of your surgery, but do it in a safe manner.
Can I ask Pedro questions?
Yes, go ahead.
Yes. Pedro, I have 3 questions. The first, why doing a PSO while corner osteotomy is so effective? And I can see a huge advantage that the limitation of PSO, that you don't have a very nice contact bone to bone. So you get at the cranial part of your osteotomy sometimes the site of pseudarthrosis. So probably you're too humble, but it's not just a variant. It could be a nice improvement of PSO. So it's excellent, I would say, solution to avoid those site failures on osteotomies. My first question. The second, I also like mechanical chisels, but I'm doing today my preference is toward the piezoelectric. But as you said that it creates necrosis, I agree if it's not irrigated. But if you have a full irrigation, you don't see any burning bone, and having a nice chisel always is hassle in our department. So if you have a mechanical chisel that you have to hammer like hell to cut the bone, is dangerous. And it's well known today that we save some blood loss. So I won't be so black and white with piezoelectric because especially at the thoracic area, it makes it more safer and more elegant, I would say, than hammering. And my third questions, I don't remember, but it will come back. But anyway, so please, what is your indication for PSO versus corner?
Well, I do corner every time, because as you say, it is not a guarantee against non-union. It is not. We have seen the lady I showed you before, the first one, she went to 8 years of post-op, of follow-up, very nicely, and then she broke the rods. And she had imaging of fusion. So I don't think you have a guarantee, but it has been 8 years, not 2 years. So I think that there is a decrease or a delay in the mechanical failure. So I think you are right, but I cannot tell that this is the solution. Second point, piezoelectric scalpels. Yeah, I maybe I have been overstating my position, and actually, as I told you before, I'm trying to pay more attention to blood loss in the last couple of years. So my posterior resection I do with a drill, because I do 2 troughs and then remove with a drill because it's cheaper. But in some occasions I use also the ultrasound. And you know, when you come from orthopedics and you don't see that bone is bleeding, you are worried about fusion. But I don't have data to support that this is a problem.
I get my third point also. By your delta construct, you link this force, third and fourth rods to the lower screws or to another point of fixation. Because if you enhance the strength of your rods by keeping the same anchor to the sacral and upper, what you're enhancing is the strength of the rods, but not the strength of the fixation. Maybe you're making it more rigid. But my question is, I saw this and I looked at it. If you get another point of fixation below, it makes it more convincible. I mean, it's if you link your rod to the rod above and then to your sacral screw below, what are the rationale of this?
Yeah, you are. I think that your thinking is very appealing, and I'm going to try this variation you suggest. It's going to be the Assaker's variation to the delta rod, Asa rod. But
it will be a shame. I'm a neurosurgeon.
No, it's okay. It's okay. You are going to be expelled from the neurosurgery community, the same as Honor. So the point is, Richard, that you are right. You make a closed system. Typically, we use the connectors between the iliac and S1, first connector, and the second one somewhere around T11 or T12. And the trick is to keeping that rod almost straight, so it translates posteriorly. The advantages: in the middle of the construct, it's much more stiff. It unloads the overbent part of the main rod.
Exactly, yeah.
Which is breaking that rod.
It's a weakening part.
Yeah, and because overbending the rod weakens the rod. And third thing, it translates the concentration of stress to the connectors area. So it doesn't mean that it doesn't break, but when it breaks, it doesn't break around the osteotomy. Okay. Even again here, I have also seen delta rods broken. I have seen that. But maybe your idea of going with the delta from T12 to a different iliac screw could make full sense. It could make full sense. So I'm going to try it.
What I've actually been doing, without knowing it's called a delta rod, what I've actually been doing is I've been placing S2AI screws with a medial start point. So not having my S2AI screws in line with my S1, doing a medial start point, and then having my rod going up past the osteotomy site, starting at my S2AI screw. So accomplishing the same thing with a separate fixation point. And if I'm really concerned about bone, I'll do a traditional iliac screw and get 4 points of pelvic fixation as well.
Yeah, maybe the only mechanical disadvantage of this is you have a very long block of the spine. When it bends, it's going to overload those individual screws.
Please.
Yeah, and with the typical configuration, you overload sets of screws which are linked, the iliac and S1, etc. But
Pedro, let's do a finite element analysis of variants of fixation, independent screws above and below, or linked to the rod above and independent screws on the below. So it might be very interesting because this is purely
biomechanics.
Very smart, yeah.
So it's going to be a finite element analysis for Richard Assaker's variant of delta rods.
Go ahead, Owner.
As I told you, I learned the delta rod technique from Beriano. The case that I have done, that I have seen her cases, I have put only one delta rod and I put it on the coronal imbalance side. When you distract it, you get a very well-balanced coronal balanced spine. But if you look on the sagittal plane, because of distracting, the sagittal gets imbalanced. He had not told me that.
Well, Honor,
But
you
yeah,
have
sorry. Then I learned that you have to put an extra rod to the other side. Then you have to compress it so that you have a well coronal balance. Then you have also good sagittal imbalance. The rod there you are compressing brings the rod back again to the sagittal plane again. Thank you so much, Pedro.
Honor, maybe you have missed one article we published about this, which is called like something like the kickstand and the tie rod. Yeah, and what you are describing is exactly if you do a kickstand, you reduce lordosis. If you do a tie, you rebalance coronally and you increase the lordosis. So it's also a way.
May I ask a question to all faculty? Did any of you have a problem with especially in the congenital scoliosis cases? The patient is walking during the anesthesia. When the patient is lying on the supine position, there is nothing. You get the neuromonitoring. Neuromonitoring is fine, but when you change the position to prone position, you lost the position. You use the neuromonitoring. You cannot start the surgery, even on the Jackson table. Have you any experience like that? And if you had, what did you do? Did you start it?
The only time I've had that was in somebody that I already knew had a cervical stenosis. So he was actually a traumatic kyphosis that I was dealing with, and when he went prone, we lost potentials in one of his upper extremities. And there, all I did is I just flexed his head. But that's one I knew going into it. He had a fracture that was unstable, so I had to do the thoracic before I did the cervical. But that's the only case I've had where I've lost potentials just with positioning. We actually recently had one with one of my partners where it was a massively obese person that they transferred prone and lost potentials. And what they ended up doing with him was actually bringing him back another day, doing a laminectomy across the apex in the lateral position before then transferring him prone to do the procedure, and they were able to get through that way.
Okay. I have one case exactly as yours, Honor, and I'm waiting for surgery because this is the girl I discussed removing the screws. So I brought her back to the OR, and this time when she was prone, she lost potentials. And now she's waiting for surgery. And I don't know how to deal with this. It's a congenital scoliosis.
Okay. I think we came to the end of the meeting. Paolo, do you wish to say anything? Nikolai?
Well, just to thank all the participants. There's been excellent, outstanding presentation and a very live discussion that is always very nice. Sometimes we don't have time to discuss this, and that was an advantage of this meeting. So I'd like to thank Doc, Mehmet, and Obad for putting this program together, and all the speakers for their engagement and their excellent input to this program. Thank you very much.
Yeah, I thank a lot to Richard Assaker and Pedro Berjano for spending time with us, and also other speakers. Thanks a lot. Doc, do you wish to say?
I just the last I would like to put in a plug for Imad, who is the behind the scenes person who makes this all happen. Thank you very much, Imad, for all your hard work. It's more appreciated than you'll ever know.
Thank you, Imad.
And also, can you have a group photograph before we go? Can everybody switch on their videos, please? Please switch on your videos. Sandeep, wake up.
Okay. I just wanted to say that after listening to all these talks, I'm very happy that I don't do deformity surgery.
Can we all
That
switch
is
on our
very
videos,
important.
please? Thank you.
This is not a good conclusion.
I think we need to take Honor out for a drink. I think he needs that. Richard, brilliant. It's a brilliant talk from you. Thank you.
Thanks, Salman. Nice.
All right.
And good to see you. And I think Pedro gave a brilliant talk. And I think all keynote speakers were brilliant yesterday, both Chris Sheffrey and, I think everybody gave very, very nice talks. Really enjoyed it. Thank you,
All right.
Doug and Co for putting up such a great show.
Okay.
Thanks a lot.
See you
Bye.
soon, guys. Bye. Bye.
Okay.
Bye.
Cheers.
Bye-bye.
Bye-bye.
Bye-bye. Thank you,
Thank you.
Richard, Pedro. Bye-bye.
Ciao.
Thank you.
Ciao, Richard.